Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello, I'm Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast, where we share the most up-to-date education for healthcare professionals. Welcome to our episode on pulse oximetry, what impacts accuracy. We're going to delve into the hidden truths behind this medical device and its actual impact on patient care. And it's actually a critical issue in healthcare. We may not have known that this was a critical issue until just recently, but this is a critical issue, the accuracy of pulse oximetries and of pulse oximeters and their potential bias against patients of color. Did you know that pulse oximeters, a staple in monitoring oxygen levels, might not be as reliable for everyone? Recent studies have actually shown that these devices can give inaccurate readings based on skin tone, leading to significant clinical consequences. And I do want to point out that the margin of error for these devices, though it may seem to be seemingly small, it can actually be clinically significant, especially in critical care settings, and especially if it's you or a family member that experiences the issue. Joining me for this discussion is Danya Winters. Danya, first, thank you
Hi.
so much for being here today for this very eye-opening topic.
Thank you for having me. I'm really excited to be here. It really is an important topic.
Yes. And second, can you share how you became interested in this topic?
Sure. Actually, I was a frontline COVID nurse, and there were some trends that came about that we kind of noticed at the time, but we didn't really have a lot of time to pay attention to them in the moment because there was so much going on. But I did notice that for some reason, some patients' pulse oxes were not matching their symptoms or their ABG results very well. And I didn't notice that whether it was color oriented this whole time. I thought it was COVID oriented. I thought it had something to do with the disease, not the skin tone. It wasn't until after that I started doing some research for a book I'm writing that I found that it's a syndrome, so to speak, called well, not really, but hidden hypoxemia, it's called, or occult hypoxemia, silent hypoxemia. And it actually is predominant in African American males where the pulse oximeter gives a falsely high reading. And that made so much sense when I reviewed clinically what I had seen during those 18 months. So that's how I found out about it. Everybody should know about it.
And we're going to really dive into what you were just mentioning as we go through today. But I'm really excited for us to really uncover the science, the origins of the problem, and just really talk about a potential path forward towards more equitable care, because that's what this comes down to is more equitable care.
Yes, it would seem like this small issue, but it's like somebody turning on the light on a much bigger issue that a lot of people don't want to talk about that we absolutely have to talk about.
Agree. Absolutely. Now, I want to start at the beginning. A lot of us, we walk into our rooms, we put that pulse ox on their finger, we wrap it in the critical care unit, because that's where I spent a lot of my time as well through COVID. But we don't really pay attention to how the pulse the meters actually work. It's like a tongue twister today to get all that out, but how they
Right.
actually work. We get our reading and we move on about our day to the next thing we have to do, the next patient, and just making sure that our patients are well cared for. But let's start at the beginning. How do these pulse oximeters actually work?
Well, it can be kind of deceptive because this whole time we think it's actually measuring oxygen, right? But it's not really doing that at all. Um, the pulse oximeter works by measuring two different kinds of light and then doing a bit of math. It doesn't really have a whole lot to do with oxygen in and of itself. So, for example, oxygenated blood absorbs infrared light. Unoxygenated blood absorbs just red light. So the oximeter, the device, is programmed to take the light frequencies of infrared, the light frequencies of just red, create a ratio and display that ratio as a percentage. So let's make it easy. Let's say you've got a patient that's in respiratory distress and you put that pulse ox on them. The pulse ox, say it absorbs 4 waves of infrared light and 1 wave of just red light. And that sounds pretty encouraging. It sounds like, okay, we've got 4 waves of saturated oxygen and 1 wave of unsaturated oxygen. But that's a 1 to 4 ratio, right? And 1/4 is 25%. That means 25% of that blood is unoxygenated, which is going to reflect back on the oximeter as a 75% pulse ox, which means your patient clearly is in respiratory distress. That's how that works. It's just light and math.
No idea that math was a
Yep,
part of
right?
the internal
Shocking.
computer of the meter. I really had no idea there was a lot of internal things in that other than just that red light and then, the display that shows me. I had no
Right.
idea. So that means that light absorption is basically the central piece that to how it functions. And
Yes.
are there different wavelengths? What is the role of different wavelengths?
It's the infrared versus the red, like I talked about. The infrared has a different wavelength than just the red does. So when it's pulling those wavelengths, it basically can tell the difference between an infrared red wavelength or just a red one. And then that's how it determines oxygenation versus deoxygenation. So it has to do with how our skin absorbs light, not how oxygenated we actually are. It has to do with how we absorb different wavelengths of different kinds of light.
And how skin pigmentation should have in the beginning played a factor in the wavelengths because I mean you have different colors. Each color has a different wavelength for
Yep.
light.
Yep.
So and then we have different colors of skin. So you would I guess I'm trying to understand here how we
Right. So
miss
let's,
a big piece of light wavelengths.
yeah. So if we just look at what we know about basic color, not even medically, not to do with medicine, most people know that like white reflects color. Dark
Mhm.
absorbs color, right? So white is the absence of any color, dark is the collection of all colors. So, for example, I grew up in Wisconsin. In the wintertime, we need a whole different set of sunglasses than we do in the summertime because the sun reflecting off the snow is blinding. So, if you have a device that was tested around Caucasian skin, which is we call it white, but it's not so white that it's reflective, right? So this device was created around to work for Caucasian skin, and it does. But however, you put a darker skin on there that absorbs more color than light colored skin because dark absorbs more than white. What's happening is you're getting a false high because all of that device is meant to do is count color and create a ratio. That's it. It has nothing to do with actual oxygen. So it perceives that more light is being absorbed because of the darker skin, because dark absorbs more light and it's reflecting a higher O2 saturation rate than what the patient of color may actually have. That's a that's a big deal.
It absolutely is. So, how did researchers first discover that these meters were giving inaccurate readings in patients with darker skin? I mean, I know
Yeah,
you said through COVID you started seeing it, but what about researchers, people who are should be researching this?
this makes me really sad. It wasn't discovered until 2020. The New England Journal of Medicine um, published a report in 2020 that noticed those differences and noticed why those differences were happening, but that knowledge never even made it to the bedside. It never trickled down to any of us who were caring for patients at a time we needed that information. 2020, that's COVID. We needed that information. But what is shameful to me is that it took until 2020 for somebody to start asking those questions about what what's going on with this disparity because I don't work in respiration. I don't work in ICU. Somebody had to have noticed this before I did in the middle of COVID. I'm not that smart. So, but it was 2020.
Right. 2020 is when I guess the first article came out where people started sharing the research into this. But how long have we had the meters?
Oh, that's a good question. That's a question I don't know the answer to. I'm not sure how long pulse oxes have existed. I mean, I've been a nurse for many years and they've always been around as far as I know. And it was just a standard of care. They don't even in nursing school, they didn't explain how they work. They're like, okay, this is what you do. And I know why they were developed. It was financial reasons, right? Because isn't it always? Um, you have a standard set, and nurses generally buy their own oximeters. You have them in the hospital, but we usually have our own, and that doesn't cost the hospital anything. But if you want to run an ABG on a patient, that's gonna cost the hospital something. $10, only $10, but it's gonna cost them something. They're gonna bill you 200 for it or bill your insurance 300 for it. Um, so I understand why the device was developed and why it seemed like a good idea at the time to save money, but that money that it saved actually cost lives.
Yes, that's, you're right. In nursing school, I never really, nobody ever really talked about it. I've never taught, I didn't teach anything about pulse oximetry meters, but in clinical, we do teach them how to chart it, obviously, how to read what it says, how to put it on. Um, but like you're saying, nobody was ever telling us how these actually work. Um, and I just find it so interesting that we've had these for a long time or something like them for a long time. And it wasn't until 2020 and the kickoff of COVID that somebody didn't actually become aware that this was happening. That blows my mind.
Same. I mean, even when they were developing the science, I would have thought some scientists would have said, but wait, if this is based on light absorption, what about light absorption for darker colored skinned people? Because that works differently. Why didn't anybody ask that question?
Or why didn't they ask that question when they were developing these?
Yeah,
We're talking about
that's
light
what I
and they're
mean. Yeah.
saying in the research how it works. And why was the question never raised early on in the research of, okay, well, light reflects differently. I mean, I know I live in Florida and I know in the summertime I do not want to wear a black shirt outside because
Exactly.
it's so
Yes.
hot. You're pulling in so much heat from the light that your shirt is absorbing versus the white shirts, the lighter colored
Yeah.
where it's a little bit cooler. Hmm. Okay,
Yeah.
so we talked about how skin pigmentation interferes with light absorption in these devices. Now, do you know how much of a margin we're really talking about? I mean, I know it is anything that affects patient care from an individual level is going to be clinically significant. It's going to be maybe not to the research as a whole, but to that person, it is clinically
Yes.
significant to them and their family. So,
Of
what is the
course.
margin of error, though, that we are really talking about?
Well, it depends on what you believe. If you believe the study says it's only 3 to 5%, and then that's still significant. But in my particular case, if I had put the pulse oximeter on a white patient that was struggling, that would have been come back to me at 75%. It came back to him as 98%. That's 23% margin right there. I don't believe those numbers are true. And if we only have one study, I don't think we can count on that 3 to 5%. We absolutely have to do more studies because I'm sure it's way more clinically significant than just 3 to 5%. That's my opinion. There's just the science isn't there to back it up, but my experience was
Yeah.
there.
Yes. Well, and it makes me think backwards too, to taking care of patients where I mean, how many times have we put that pulse ox on someone's finger who looks like they're struggling, but it shows that their percentage is where it needs to be. And so we're like, oh, it's anxiety. Let's give them medication. Let's help them,
Yes.
slow down their breathing. But looking backwards, were they really struggling? And is that somebody who, if we would have caught that earlier, maybe they wouldn't have passed away, or maybe they would not have had to have the care that they ended up needing to have because we didn't catch something earlier.
A-
And so
a-
now it just leads me to question. Oh, go ahead. You're gonna say something.
No, no, it's okay. And I mean, that's the kind of thing that haunts me, especially there was hardly anybody we were saving during COVID anyway, to be frank. And this, this just haunts me because that's exactly what we did. So many people had anxiety during COVID. They were so afraid they couldn't
Right.
breathe that a lot of times they would work themselves up into that state, right? So for this
We sit
particular
in the
patient,
rooms,
I was so
say, hey, slow
excited.
down your
It was way,
breathing.
I'm sorry.
Oh, no, I was just saying, yes, so many times we sat in patients' rooms with COVID during that time, just trying to get them to slow their breathing down because they were so anxious. They were so
Yes.
worried.
Yeah. So for this particular patient, this was during wave two. And if you worked during COVID, you know during wave two, we really didn't save anyone. We lost just about everybody. So this guy walked on my floor of his own volition during wave two, which was so exciting for us nurses. We actually had somebody who wasn't on a CPAP or a BiPAP that we could talk to. He was very flirtatious. He was an older man of color. He was really close to the nurses station too. So I was in and out quite a bit talking to him because during that time I was just on the phone with families all the time for the most part. Patients weren't very
Yeah.
responsive. So I was in and out and he was doing pretty good. And he hit his call light. And I went in there to see what he was doing. And he said he was having a little bit of trouble breathing. So I put him on 2 liters because he wasn't even on any O2 at the time. Put him on 2 liters, checked his O2, but it came back in the upper 90s. Um, so I said, I'm just going to put you on this oxygen for a little bit. We're going to see what happens. I went and made a phone call, and in the middle of the phone call, his call light went off again. So I went back in there, and he was starting to use accessory muscles. He was starting to sweat. I cranked up his oxygen to 4 and took his pulse oximetry again, and it was still in the mid 90s. So I'm like, okay, he's having some anxiety. So I did the whole thing. Please slow down your breathing. I went and pulled some PRN lorazepam, gave it to him. Um, but even by the time I came back to give him the lorazepam, and lorazepam takes a while. It's like 30, 45 minutes to peak. He was still, I could see he was just struggling. So I put him on a non rebreather, turned it way up, um, and then called respiratory. And they came and I asked them to do an ABG. And they said they need an order for that to do an ABG. And I just kind of pointed to him and I'm like, he can't wait for an order. I had no idea where the hospitalist was. I'm like, just please do it. I'll take the hit for it later. She ran it and he was in the 70s.
Oh my
So I
goodness.
hit, yeah. So I hit rapid. Hospitalist comes down, starts screaming at me, of course, for ordering the ABG without him. Um, but we were all so stressed. None of us were acting like ourselves. He normally wouldn't have done that. Just had to have a lot of grace during COVID. But I
Oh, yeah.
went up to the
Should have
ICU,
been
grabbed,
saying thank you.
yes, right. Later, he said, you know, you did the right thing that was the wrong thing and don't do it again. But I ran up to ICU. They had one available NIV because somebody had just passed away. I ran down with it. We got him on it. And then he was booted back upstairs to the ICU and he passed away overnight. So and this is how wave two went, right? They walk on your floor and they die by your next shift. Um, and I don't know that we could have saved him. I do
Right.
know I could have taken the terror out of his eyes by getting him on O2 sooner. And that's when I said, okay, we've got to do something about this. So the next time we had a department meeting, I asked if nurses could start requesting ABGs when they suspect something like this is happening. And they gave us permission to do that for the rest of COVID.
Right.
So at least we
Right.
could get them comfortable. I don't think I could have saved his life. But when I went in there with that NIV, He was terrified. I mean, it was all over him. So while they were getting him on that, I was holding his hand, telling him, we're going to get him more comfortable. I'm going to call his wife because that's all you could do. But I could have had a much bigger head start. And how many
Right.
patients like that did I have in 18 months?
Yeah. That we all had in that time.
Yep.
Yeah. Oh, it just brings tears to my eyes because, I remember being with one of my coworkers in the ICU and I couldn't find her for a while. And I looked into a room and she was all dressed out and she was just holding their hand. And when she came out, she said, I made a promise today I wasn't going to let anybody die alone, you know?
Yep.
Um, so yeah, as you're talking about it and I can feel just that, yeah, I can just feel it. I
It
can feel
comes
it.
back, doesn't it?
But
Yeah. Thanks for
it
being out
does.
there with
It
me,
does. It
by the
comes
way.
back.
It was a hard
I don't want to
time.
bring it was. Yeah, it was. It took me, yeah, it was a lot. Um, but it goes back to the lack of diversity in clinical trials.
Yes,
That structural bias and device
absolutely.
development really contributed to us
That's
not
ex
being able to identify this earlier. And
Yep.
it took a pandemic to serve as this pivotal moment to bring this issue to the forefront so that we could start having discussions like this on policy and regulatory changes. But on in research and in development, we have to start thinking about
We
these
have to do
types of
better.
things. We absolutely do.
Bec
And we're seeing that there is a specific population where this inaccuracy is particularly dangerous. You just described it.
Yes. Yep. So, I mean, let's look at the decades prior to the pandemic with the asthmatics and pulmonary fibrosis and COPD and lung cancer. All those patients of color with those diseases were suffering unnecessarily that whole time,
Yeah.
and nobody was asking the questions.
All this time, not being able to breathe well also mimics anxiety.
Yes. Yep.
So I'm seeing that in my head, and I'm seeing so many of my patients who, because I started out in a cardiac floor and then I worked my way into the ICU. And so I've seen so many patients come in
Yep.
of with colored skin who have struggled. Yes, we've had Caucasian and lighter colored skin come in who have also had the same struggles. So, in my head, I'm like, they all seem to probably be anxiety. But
Yes.
how many other patients did I have where I didn't do what probably they needed done because I didn't know better? I
Right.
didn't know potentially that what I was seeing for their vitals was not actually what was
Was not real.
happening in
Right.
their body.
Well, we trust our
Uh,
devices.
yes, and we trust a lot of our policies and guidelines, and we're thinking, well, they've done the research, and I know
Yep.
for me, a pulse ox, those readings have been around the entire time I've been on this earth,
Yes,
basically.
exactly.
Um,
And the
why would I
tachycardia doesn't
doubt
tip
that
you
they
off
don't
because
work?
you have that with hypoxia and anxiety. So that's not a clue either.
Yeah. Yeah. So, um, this is not at all to make anybody feel guilty. It does make
No,
me think
no.
backwards. And I think it's going to make all of us think backwards as well.
Yes.
And it's because we care about our patients and we
Yep.
care about their experiences and what they're going
Of
through. And we
course.
should. And that's what makes us amazing and great profession and enjoy what we do. Um, but I think it is going to make people think backwards. And I just want to throw that out there. This is not to make anybody feel guilty. Nobody knew. Nobody knew that this
Right.
was
We didn't
happening.
know.
Nobody knew
Exactly.
that they didn't work the way they say that they're working.
Yep.
We didn't know. We know now. So
We know
now we
now.
can do better because we know.
And we have a responsibility to change it because we know.
Yes. So now I want to just kind of talk about clinical consequences and kind of those implications that we're seeing. Earlier, you mentioned the occult hypoxemia. So, what is occult hypoxemia and why does that matter clinically?
So, occult hypoxemia is exactly what we've been talking about. You might hear it referred to as hidden hypoxemia or silent hypoxemia. It's when the reading on the device does not match the clinical manifestations of what's going on or the ABG and or the ABG. It's a deceptive reading. It's a false high reading. And of course, that is significant because your patient is in respiratory distress and you're unaware and you might be calling it something else and medicating it another way when a little morphine or some oxygen or COVID aside, even like with COPD or pulmonary fibrosis or even lung cancer, when the lungs are full of cancer, that's a whole different route than treating anxiety if your device is wrong, right? As a nurse, we're always critically thinking, okay, my device is telling me it's not oxygen. So what else could it be? And you're just ticking. What else could it be? We're going to medicate that. I'm going to call the doctor. I'm going to say, this is what I'm seeing. And they're relying on me to tell them what's going on. Well, the O2 sat's 95. No, it's not. Let's get an ABG. The O2 sat's 80. That's very clinically significant.
And typically, when we're checking our list in our head, if our O2 stat is good, we're not going to jump to, hey, can I get an ABG? Because
No,
we're believing what we're seeing on the monitor.
exactly.
So that's not where my brain immediately goes. If I
Right.
treated everything else that's in my head that I'm checking through, then I'm like, okay, maybe
Yeah.
we should get an ABG just to make
Yeah.
sure that we're not missing something else. But it's not going to be the first thing I think about if my pulse
No, I
ox
mean,
is within normal limit.
I would have to see like cyanosis,
Yes.
diaphoresis, a lot of accessory muscles. I'd have to see that for and there's a great deal of discomfort between here and here. Um,
Right.
but the earlier signs aren't going to tip me off to that for sure.
And if we get to those later signs that you're talking about, usually our outcome is not going to be as good as it
Exactly.
would have been had we caught it earlier before we started seeing the the really bad desaturation symptoms. Um,
100%. Right.
and I think that leads us to what are some of the clinical consequences when we are thinking we're seeing an oversaturation. Basically, it's an overestimation of what's of this oxygen saturation in their blood. So, what are some of those clinical consequences?
Yeah, those are respiratory distress. And like you said, more poor outcomes, transfers to higher levels of care, death.
Bam. Yes. Yes. Bingo. And if we're having trouble with our hospital administration understanding what we're saying and why we're asking for an ABG, even though the pulse oximetry meter is reading, high, well, if we're having to increase their level of care, if we're having to put them in ICU, well, we've taken ICU beds away, we are now costing you more money
Yes.
trying to care for this patient had you just let us get an ABG and we could have caught this early on.
Yes. And that's kind of how you have to talk to them too. You have to hit them where it hurts them. Because
Yeah.
unfortunately, what hurts us isn't the same as what hurts them. So, yes, if
Right.
you put it bottom line financially, you're going to be paying more out of pocket because it's going to be a higher level of care. Your mortality rate is going to go up as a hospital, which is not good for them, their numbers. You have to hit them there because that's what they understand. Um, and and that's what's hard because as nurses, we just want to scream about patience and quality of life all day long, but we have to hit them where it hurts them, and that's where it hurts them.
And most of us, we didn't go into nursing strictly for the pay. Yes, we enjoy being paid for our job, but we actually went because we care about our patients for the majority of us, for our entire profession. I mean, we are one of the most trusted professions for how many years now? I mean, that really says something. But then to hear that as a nurse, I can't trust my devices. How many other devices can I not trust?
Right. And exactly. And I mean, I think a lot of nurses look at that when it comes to like blood pressure cuffs and things like that. If it says 70 over 30 and your patient's sitting up talking, eating, you know to take it on the other arm, to get a different cuff, things like that. But we've never had to question that with an oximeter. It just never crossed our minds.
Well, and if I don't trust the machine for a blood pressure reading, I'm just going to go take a manual. You know,
Right.
I
Exactly.
can't do that with a pulse ox meter.
Right. it's an ABG. You have to do something else. Yeah.
Right. Yeah. Right. But then I have to have an order to be able to do that. I don't have to have an order to go take a manual blood pressure, but I
Right.
have to have an order to
For
go
an
get an
ABG.
ABG if I don't trust the pulse ox machine.
That's right.
Isn't that interesting?
Uh-huh. Yeah, it brings up a lot of stuff. It brings up a lot of stuff medically, and it brings up a lot of stuff ethically, of course. I mean, that's the huge
Absolutely.
issue, but even medically, like, do nurses need a little more autonomy? Will that help? Yes and no. I mean, we need devices that work, that do their job. We need a device that measures oxygen, not light.
So that leads me to ask, how do disparities in readings contribute to broader health inequities that we're seeing?
Right. So this just leads to, like, some of the big issues that a lot of people just don't want to talk about. You don't have to believe in privilege for it to be true. You don't have to believe in marginalization for it to be true. And they're both true. And when you work in healthcare, you see it all the time. And another problem was, even during COVID, you could see the marginalization because the African American culture, or the people of color, came in much worse shape. And that's because they hesitate to come to the hospital. They're often dismissed, or they don't have the kind of healthcare benefits that people not of color more often have. So a lot of times they came in worse shape. So this shines light on some of those issues as well, that we talk about but haven't really been super tackled, that absolutely have to be addressed.
Right. And I don't know what year these the research was done and these machines were developed. I don't know what year that was, but not that long ago, I did do a podcast on gender bias. Um, and, looking at the history of why women were not a part of clinical trials, while I'm not saying that it is right in any way, I did see where it fell more into, well, we're trying to protect women. What if they're of childbearing age? What if they're pregnant? We're trying to protect them just in case. And so I could see that train of thought for back then because, we didn't have ultrasounds like they do now.
Right.
You and until you were, early on in the beginning. So I could make sense of some of that. I don't know the history on when these machines were researched and developed. So I can't say why the research was only done on lighter color skin. I don't
It
know what the
it
history
still
is
is for
there.
the most part. It's always been a very patriarchal type setting for medical device testing. It always has been. It still is in a lot of ways, and that has to change too. Um, and and I get
Mhm.
that they said that about trying to protect women. I think women have been part of the marginalized population, not as marginalized. I'm not saying that at all. Um, for so long
Right.
that
But in healthcare, they have been. Yeah,
yes,
for sure.
yes. And because a lot of times women were being treated for anxiety too when they were in respiratory distress. They're women, they're stressed out, they have anxiety, they're having a panic attack. Um, so in that way, we belonged in that group. In a lot of ways, we don't belong in the group that we're talking about today. Um, but yes, we have been lumped in with that group as well. And it's just a very, like I said, it's a very patriarchal structure, and that needs to change.
Absolutely. Now, are manufacturers doing anything, or are they failing to do to try to fix these issues? Have any manufacturers
No.
came out and said,
Not
"Hey,
really. They're only going to do what they're required to do by the FDA. And unless the FDA makes those changes, changes the regulations for that, it's not going to change because for them, it's about money. It's not really about patient care, right? And
it's not clinically significant yet
yeah, and I
to
really
them."
don't see the FDA making those kind of changes anytime soon unless we all start really, banging the drum, which is what we need to do. We've got to start insisting that there be some changes. And technology, I've been looking into this. Technology is so much more forward than anybody realizes. There are potential solutions out there. They're going to cost some investment, but there are solutions out there that will totally take care of all of this for everybody across the board. Um, I was researching what's being done, and if I had an idea for something that I didn't even know if it was possible, so I started doing research on that, and it is. And once I found out it was possible, I just went ahead and applied for the patent for it. I haven't done anything with it yet, but I'm just really excited that there's things out there that we can do. They're just not being done.
Now, what role does the FDA currently play in ensuring device accuracy, just in general?
They're the ones who have all the regulations in place. So, like device companies, they don't answer to patients, they don't answer to hospitals, they only answer to the FDA. The FDA is in charge of all of that, of setting those rules and parameters for them. So, they, and the FDA is it's a big part of our government. It would take a lot for them to change what they're doing. They would have to come under a lot of pressure or threaten to have funding pulled or then we start getting political, which is unfortunate because healthcare should not be politics ever, and it is, and that's a big part of the problem.
Now, do you think that pulse oximeters maybe should be reclassified as high risk devices to just improve the oversight of them?
That would help. Right now, they're only a class 2, so they don't have which is considered low to moderate risk. But now that we have this information, this is high risk. This is a high risk
Yeah.
device, and we just don't look at it that way, but it is because the misreadings are a life or death consequence. So bumping them to a class 3 would certainly help. It would require more rigorous testing. The device companies would have stricter parameters and they would have to go about it differently. But I don't know how you can't change physics. Physics are what they are. Light absorption is what it is. If you are doing a device based on light absorption and math, that's never going to change. S- So even moving it to a class 3 device, I don't know how that would help because science is science. We have to do something completely different, I think. That's just
Would
my opinion.
change.
Pardon?
You would think the math would change. You would think that the math for a lighter skin tone versus darker skin tone would be different.
True. Yeah,
Like
you
there
could
should be two settings,
yes, I
one
was
for
gonna say
light
you could
colored
do a
skin,
separate
one
setting.
for
Sure, absolutely.
yeah.
But you've got people that are in the middle too. It's not just like, you know, really black and white. You've got Hispanics, you've got lighter colored African American people, and then you've got very dark African American people. And so that spectrum, I just think allows for a lot of error.
Absolutely. The more choices we have, the more opportunity for error.
Yeah, and
And
it's
you're exactly
subjective.
right. Mhm. Right. So, what can frontline healthcare providers actually do to compensate for these inaccuracies that we're seeing?
I think I think you have the healthcare providers that rely too much on medical devices, and you have healthcare professionals that rely a lot on their own brain. So I think we need to really emphasize critical thinking skills even more in nursing and medical school. You have to, in your gut, nurses have nursing guts. We really do. It's a thing. Um, if something is telling you that something's not right, you have to honor that for your patient. If that means you're pushing the hospitalist or the house soup that doesn't want to give you what you just keep going till you get what you need. And I've always been kind of that nurse anyway. It gives me a love-hate relationship with doctors in the hospital because I will advocate for my patient,
Right.
practically to walking off the floor. Um,
Right.
but things aren't adding up. There's a reason for that. If you're seeing a lot of this when they're breathing, they're starting to sweat, um, there's no reason to think that they would be anxious, then that's telling you something. So you have to start looking as the devices as like a helper, not a diagnostician. right? It's
Right.
there to help with what you already know in your own skill set. It's not there to make decisions for you. You just have
Yeah.
to start looking outside of those devices at what else you're seeing in the big picture. I think that's the only thing we can do right this second.
Did you know that the meters were classified low to moderate before you started looking into them?
Nope. I didn't know that
Because
in
it would
nursing
just see,
school. I didn't.
no,
Mm-mm.
I didn't either, but I'm thinking, yes, low to moderate. So if we all knew that the risk of these devices could hit in the moderate area, would we have been more likely to be like, this isn't adding up? Let me go ahead and get the APG.
Yeah, possibly, possibly. And I think they actually need to be a high risk. We need to know it's a high risk, and we need to know what that means. It means it's a moderate to high risk of us depending on those results. There's a high to moderate risk that that might be wrong. If it's
Right.
low to moderate, and we're not even taught those risks, we're not taught those classifications. And that, I think that would be something that we need to rely on too. Just like we know that the pulse isn't always right, why did we assume the oxygen was right?
What documentation purposes do you find are useful when we're suspecting there's inaccuracies in our SpO2 readings?
So here's where I want everybody to do as I say, not as I do, right?
Yeah, oh
Um,
yeah.
we're taught so much how important documentation is, and it truly is. Now, I won't lie, during COVID, there were times where I sat down after my shift was over, pulled out like 6 pieces of paper, and did all my documenting for everybody for the whole
Okay,
day.
wait a second. I was doing
Right.
that before COVID. Let's be real.
Okay, yeah,
You've had
right?
those days.
So, yes, you do, and that means you're missing trends. You're missing a lot that we should be able to be keeping an eye on, and that's a whole other can of worms that has to do with nurse ratios and things like that. That's a whole different
Yep.
education class.
Workload. Oh yeah. That's a
But
whole nother like 5 different podcasts is what that is.
right, exactly.
Yes.
Um, but I think one of the things that's important for nurses to do to document is not just write down what the O2 is, because we don't know that that's true. We know what the SpO2 value is on the oximeter. So instead of writing O2 is 90, no, we don't know that that's true. We know that the SpO2 equals 90%. So we're not making a judgment about the oxygen. We're documenting the reading on the device.
Change that.
And then, okay, SpO2 equals 90. However, patient is complaining of shortness of breath. Respiratory rate is 24. Um, Patient is diaphoretic, tachypnic, just not just the readings. We can't be documenting the readings. We have to be documenting what they're complaining about, whether we see it or not, what their complaints are, and then what we're seeing as well. And I think if we start getting that specific in charting, which is really difficult to do, but if we do that, then that's going to shine light on some areas that are missing. And if we
Mhm.
ever had to testify or whatever, we can say, see, I said, this is what's happening with the patient. This is what the device was saying. The discrepancy is there, but it requires really specific charting, which requires time to really specifically chart.
Miss miss paper charting. You know, and in the unit you had it was like you flip it this way, you flip it all these different ways, but everything I needed was right there, but I could write exactly what you're saying. I could write long form exactly what I wanted to say. So
Yes.
I wish a lot of times when I'm looking at charting that I would have my vitals right here at the top of the screen, and then right underneath the screen I would have my notes section, and I could just type. But
Yeah.
charting today has gone to basically charting by exception, and you're like clicking
Yes.
all these things,
Yeah.
and you don't, by the time you're going through 10 pages of clicking things,
Yes.
you don't even remember what you want to put on your note anymore.
No. Nope. And they're kind of charting, teaching you that less is more, but it's not.
Mhm.
More is more.
No. Right.
And I think a
Especially if you get
text,
called into court.
yeah, a talk to chart app would be great too. If you could just speak your narrative, or real time talk about what you're seeing as you're seeing it. I
Mhm.
mean, and that technology is out there. They just don't want to spend the money on it. But it's talk to text has been around for how long? A long time. But we need to start creating clearer pictures.
I agree. Absolutely. And that's for everything, not even just showing that these inaccuracies, or we're seeing
Right.
these inaccuracies, but I mean, so much that we document should be documented that we don't have time to document, or we don't know how to document it because we got to go through 10 pages of check marks. I hate
Yep.
those check marks so much.
And yeah, I'm a certified legal nurse consultant as well. And I'll tell you what, that lack of charting will get you in trouble in court every time. You'll lose your license.
I overcharge. I
Yes, same.
Because I worry about that. So I'm like, nope,
Yes.
I'm checking all the things. They're like, oh
Yeah.
no, you just gotta check what you didn't, charting by exception or whatever it is that they do. And I'm like, no, no,
Right.
no. I'm charting all the things.
Yes. Especially if I saw something and asked for something and it was denied.
Right. Yeah. Put that in there as well.
Yeah.
Now newer meters. Are we seeing any better ability to address skin tone disparities in any of the newer machines that are coming out?
No, not really. Some of them say they're working on it, but they haven't offered up any proof of concept or I haven't found any real trials out there. It's like either the information isn't being presented to these device companies yet, or they don't care because the FDA regulations aren't out there. I'm not sure which it is. It could be both.
For the responsibility to
Yes.
face this. True. Very true. And, I don't really see a lot of the different hospitals I've worked in. You'll see new meters come out for sugar, for checking their sugar. But I do not see a lot of new SpO2 monitors coming out. Like, I don't see them buying them. I just see the old ones.
And just following your ABGs. I mean, your ABCs, your ABGs, your ABCs,
All the
the
things.
airway is more important than blood sugar. So those oximeters should be at least as important as us. The way we track blood sugars is crazy to me anyway. How often we do it and for everybody, and especially stress causes higher sugar levels. So that's not really real either. But the oximeter should at least be held to that standard.
Absolutely. Now, I want to look at just some broader implications of this bias that we're seeing. Are there other biometric devices that also show racial or skin tone biases, like facial recognition
Yes.
devices or wearable
Yes.
devices?
Anything that's like um, sensor based works on light, works on wavelengths. So yes, there's like a 35% discrepancy, I think, on face sensors in African American women of color. Yeah, yeah. So all of those things need to change. It's like the testing that goes on for devices globally seem to think that the world is white. And we are actually an extremely narrow margin of global color. Yet everything that we develop, all our tech, is based on white male patriarchy. It's insane to me. And I mean, that's not just the United States, it's happening everywhere. It's happening in countries of color. And
Hmm.
I just can't make that make sense in my head. I don't know why that's happening, but that's exactly why all of this is happening because our tech is built around and by both. It's tested and developed by mostly white men,
Right.
and that's a problem.
Yeah. Why do you think that the algorithmic and hardware bias that we're seeing is so widespread in medicine? I mean, I know I talked about gender bias and the thoughts way back in the day when things first started. But again, back then it was a patriotic,
Yep.
pa-
Patriarchal. Yeah,
yeah,
I know what you mean. Yeah.
patriotic, like not patriotic.
They
I'm
thought they were the
combining
same
multiple
back
words
then
together.
anyway.
Yeah,
Yeah.
I think so. Yeah.
um, I, I think it's just I think nobody's just really sat down and said, "Hey, is this still working for us?" And it's just been passed forward and forward and forward. Here's our test groups. Here's the people who are designing it. And nobody's just ever stopped to question it. Hey, this isn't our patient population. Mm, I don't have only white male patients on my floor. You
Yeah.
know, nobody's, I just don't think anybody's asked, hey, is this still working for us? And I think the population of color is so tired of banging the drum for everything and not being listened to or paid attention to. Pulse oximeters are the least of their concerns, quite frankly, I'm sure. They have much bigger fish that they're trying to fry. Um, and that makes me terribly sad. It just shouldn't be. Our technology development and testing needs to be as inclusive as our population is. You know, white testing subjects should actually be in the minority of testing subjects because as a global people, w- we're in the minority. Um, and I think it's just this is the way we've always done it. How much do we see that in medicine all the
Yeah.
time? We do it because this is the way we've always done it. That's not
Yes.
working anymore.
Yeah. But how can we advocate for more inclusive and equitable medical device development? Where do we start?
I I think now that we know better, I think now that the information is out there, especially healthcare providers of privilege like we are, I think we are the ones that have to start pushing that forward. We have to start putting pressure on administration. We have to start putting pressure on FDA. We have to start putting pressure on other regulatory bodies of government, legislature, Congress. I mean, we just have to start. There's a
Right.
lot of other things like that that are being created right now. There's a lot of movement out there. So it makes a difference. It can be done, but it's going to I think it's going to have to come from what's considered the privileged group. Um, I imagine the other populations are not only tired, but they have a history of just not being represented well. And I think, it was Maya Angelou that says, once you know better, you do better. And And I think having that knowledge, we are absolutely responsible for trying to press for that change. I think that lies on us.
Absolutely. And as we've been talking today, some of the things that I've thought about is, from a leadership perspective, if you're in a hospital, if you're in a facility that uses these devices, which the majority of our facilities do, from clinics to hospitals to rehabs, it just seems that we might could start with changes to our guidelines. Changes to the guidelines and the fact that if we know that their symptoms that we are seeing, that we're observing, do not match what their pulse ox reading, their SpO2 reading actually is, that we can push for getting an ABG.
Yep.
Can we, where do we start with that? I think it starts with education. Until we can changes are made, I think we need to advocate for education for
Yes.
all healthcare providers that this is happening.
Yes.
And then we need to push for accountability and being able to take care of our patients. Hey, this
Absolutely.
patient needs an ABG. Yes, it might read that it's a 95% SpO2 reading, but they do not match that.
Yep. Take the $10 out of my check. I'll pay for it if I have to. Right?
I mean, if I'm
Just
wrong,
give me yes, exactly. If I'm wrong, yeah.
right. So I see that as being a start that also helps us to advocate and push for more inclusive technology design as well. I mean, my priority, my head immediately goes, how do I take better care of my patient now that I know
Right.
this?
Right.
Now, how can we start pushing for inclusive technology design from the start?
Yeah. Yeah, exactly. And that's, the inclusive technology, that's when you have to start pushing government and regulatory bodies. But I agree with you.
Yes.
Absolutely. I agree. It starts with educating our institutions that this is going on. What kind of policy and procedure changes can we make in house to cover that? Can we give nurses a little more autonomy? And now, as you know, you have nursing students rotating through your units all the time. The education can start there. If they're not getting it in school, it's our job as senior nurses to pass that on. So if you get an example of that, if they're on with you, I love that when that happens. You're like, okay, do you see how he's struggling? And we have 95% here. What do you think that could mean? What should we do next? Get them thinking that way. So the next generation of nurses that come up are already kind of in that mindset. But you're right. It before we can make the bigger changes, because that takes so long, it needs to start in-house.
And I love what you said about documentation, where we're not we don't actually necessarily know what their O2 saturation is,
Right.
but we can tell you what the SpO2 reading is, what
Yes.
the value is on the machine. Does not necessarily mean that it is correct, but I can tell
Exactly.
you what it said, and then I can tell you what other
What I
things I
see.
saw and observed with the
Yep.
patient, and I can tell you what they complained of. I think that is so important too. So I'm glad you
Yes.
pointed that out. Now I
Yep.
want to ask you, if you had the ear of the FDA or any major medical device company for that matter, what would you ask them to change first?
I would ask him to kind of start from scratch, get rid of that technology altogether. What I want to see, and this is what I applied for the patent for, so I can talk about it because it's already covered. But there's technology that's available that can be put into, like, those Listerine strips that are dissolvable. That little sensors can be put in those and placed on the patient's tongue, and the oxygen can actually be detected through saliva. And you can get an O2 reading, you can get a pH level, you can get a glucose level, and they're digestible sensors. They're just, you can't even see them, they're small. And it dissolves on the patient's tongue and it transmits wirelessly to a monitor. You have to actually measure oxygen. You can't measure light. We have to measure oxygen. So that's what I would say to a device company. What if we just started from scratch with what we know about the body and what we know about technology, and we could just start over? How could we do this differently? And then color and gender is not an issue. It's chemistry.
Yes. And I also think that if we could have the ear of the FDA to say, let's go back and look at our regulatory requirements for research.
Yes.
How do we make sure that it is equitable for everybody?
Yes.
Color, gender, short, tall,
Age.
big,
Mm-hmm.
small,
Yep.
age, young, old. How do
Size.
we
Yep.
make it more equitable across the board so that we're not continuously running into these issues? We run into these issues with women, we run into these issues with skin tone. Now think about the woman with a darker skin tone as well.
Right.
I mean, that's you know, you can continue to step on all of the inequalities from
Yes.
age to skin tone. How can we make this equitable so that we can take better care of our patients?
Yep. That's exactly. Yep. And that's the question that they all need to start from.
Yeah. How can this conversation we're having today spark broader changes in research, education, and clinic?
I I just hope that whatever students or nurses listen to this podcast are as astounded as we were by some of the things that we found and get just as indignant and righteous as we feel about it. Because I think once we start coming together as a global community, start asking for change in our clinics and our hospitals and things like that, then then you get a movement started. Then things really start to change. It just starts with conversations.
It's out there. If you want to take this
Yes.
to go to your leadership, I will say most of the time when you want to see a change in an organization, you have to show them how it's going to hurt them financially. And if they don't really dwell on it as much as we do about the patient
Right.
it, as a
Right.
as a number, to them it is the big numbers, but there is data, there is research out there that you can take to your you have to find it though, you have to dig for it, and it might
Yep.
be that you have to do the research yourself in your facility. So maybe you set up a small study in your facility to try to show these discrepancies firsthand and how they're happening, because there is not a lot of research happening about this. This was just determined, and so it's been kind of quiet,
Right.
but maybe you
Yes.
could help the voice get louder and louder to show.
Absolutely. I
that this is an
agree. And
issue
if
and we
anybody's
need
going to
to
do it,
fix
it's going to
it.
be a group of nurses.
Yes, absolutely. Because it's our patient. We need to take
Yes,
care of our patients.
yes,
Yes.
yes.
Well, Danya, is there, as we, come to the end of our time together, is there anything that you just want to make sure that you covered? Anything you want to remind the listeners as we come to the close?
I just want to remind everyone that once you become aware of something and have that knowledge, you therefore have a responsibility to do something about it. Because if you don't, then silence is complicity, and we've had enough of that. So once you're in possession of knowledge, you're just as responsible as anybody else for making that change.
Absolutely. I agree completely. Thank you so much, Danya, for joining me on this discussion to just really uncover and address these biases in places we didn't even realize that they lived.
Thank you, Candace, for inviting me. I mean, we could talk about this subject for probably a week and never cover it all, but I hope we've uncovered enough that really opened some people's eyes because this was all very astounding to me when I did my own research and found out about it. So I'm hoping it just really opens people's eyes.
Yes, and to our listeners, we are seeing disparities in our care for gender as well as color, and maybe not intentionally when they were developed. I don't know the history about the meters and how they were developed, but you can check out our podcast that we released on gender bias to hear some history on how we got to where we are there. And now we are learning the importance about skin tone and how it's relevant to research. So as we take time to learn more, we get to correct, we get to do better moving forward. So it takes us being together to really push for change and just ensure that healthcare technology and healthcare research in general just serves everyone equally. For our listeners,
Absolutely.
thank you for joining us. And I
Thank
encourage you
you.
to explore many of the courses that we have available on elitelearning.com to help you continue to grow in your careers and earn CE.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.